Hello, and welcome to our week learning about assessments. So, assessments obviously are not a model, but can be helpful in any and every model, and also just for kind of practical purposes. So, as a marriage and family therapist, we do, once you get fully trained, have the training to diagnose. And that's an important aspect of the services that marriage and family therapists offer. It's something that they've kind of had to fight for, that right to diagnose. And it's essential in order to have it be a kind of a viable profession, because in order for insurance to ever pay for the therapy, there needs to be a diagnosis. Insurance won't pay for something for which there is not a diagnosis or some kind of code. So a lot of the codes that we use come from the DSM-5, and I also use the ICD-10, which is the international version of the DSM. The DSM is basically like a manual of all of the various diagnoses that somebody could have, and it gives specific symptoms and says which, like how many of those symptoms and for how long somebody needs to have in order to receive this diagnosis. And it also gives differentiating diagnoses. So, for example, maybe two different disorders look very similar or have similar presentations. And so you need to have some clarification about what makes it this one instead of that one. So, what the DSM does not have is anything ideological, meaning how it came about. And that has been kind of a contention with the DSM that many mental health practitioners have had for a long time. Just saying you have this thing without any idea about how it came about, um, or having it be in a systemic framework, has made it less helpful and more pathologizing. And so there have been efforts for a long time to kind of change that about the DSM. So far, for whatever reason, the APA, American Psychological Association, which is the body that creates and publishes the DSM, has not seen fit to make those changes. Um, anyway, all of the assessments that we use, as you know, because you've done some assessments now, are not for diagnosing purposes, diagnostic purposes. But there are some assessments that are specifically for diagnosing. Some that I use fairly often. For example, there's a number of Beck inventories. There's a Beck anxiety inventory, a Beck depression inventory, a Beck youth inventory, and that has kind of, I think there's 5 different kind of axes on which people get assessed. There's depression, anxiety, I think like anger, aggression, self-concept, things like that. So that's more for the youth, like teenage, adolescent population. I think the youngest that take Beck, that Beck Youth Inventory might be 8 to 11. Anyway, assessments can be really helpful for a number of reasons. Let's see here. I'm going to go on to, well, first we'll talk about types of assessment. So when you're assessing, of course, what we've talked about in the different models, assessment is happening all the time. As you are observing a family, you're trying to see systemically what's going on here. What are the relationships? What are maybe some of the causes of the symptoms that you are looking at? So, for example, with our lovely Lee family, when you think about what was going on with each of the members of the family, you might need to look at the whole system. Why would James have an affair? Well, it's because Lydia had just died. And there was just a lot going on. And so looking at somebody in isolation can be less helpful, but having the ability to assess just by observation, by having the people in the room, is a really important first step. Observational assessments can also be more formal. For example, diagnosing an autism spectrum disorder, often there are both written and observational aspects of that. If you're doing a good one, I mean, you can kind of say, it looks like maybe there's some autism spectrum, but that's not a great idea. And there are some diagnoses that, for example, like an ASD diagnosis, that really getting some specialized training in making those diagnoses is helpful. So observation can be small things like where the couple sits on a couch. Do they sit really close and hold hands? Do they sit on opposite sides of the couch? Something as simple as that can be an observational assessment. And then that can go into treatment planning and case conceptualization and things like that. But there can be more formal observational assessments. Self-report assessment is what you guys have been giving families, where you kind of give a survey or a form for them to fill out, and they choose answers. They're self-reporting. Of course, there's pros and cons of self-reporting. It's easy and quick. Also, you never know quite how accurate it's going to be, and people may interpret things differently. I have had really well-established assessments be frustrating to clients that I've given them to, because, for example, in the Beck Depression Inventory, it goes from not at all to this does fit me or something like that. There just wasn't the range that the person wanted. And so it was like, I don't know how to report this. I don't know what to say. It didn't fit very well for them. So self-report is fast and easy, but it's also, maybe you're not exactly sure how accurate it's going to be, and how well it fits for the person. Then interview, often a lot of the self-report assessments can be done in an interview style. And all of these can kind of go together also, but interview can be more in depth also. One of the benefits of assessing by interview is that you can ask follow-up questions. So for example, if you were administering the Beck Depression Inventory and somebody said, none of the 4 options really fit for me, then you could say, oh, well, what does fit for you? Where do you kind of fit yourself? Maybe it's a 0 to 10 scale, and you instead have, 4 options, and none of those fit the 3 that you feel like you are. Other interview assessments, for example, like the adult attachment interview, it would be very hard for those to be either done with observation, because there's just things about somebody's childhood that you can't observe in the present. And self-report might be difficult also. You could have somebody write the answers to questions, but having the opportunity to follow up, to note the affect, like what's going on physiologically, what's going on emotionally as the person talks about it, is very important. And so interview pulls in observation also. So in these types of assessments, of course, having a blend of all of them is going to be the best option, so that you're not getting all of your information from only one. It's great to be able to be observant and notice what's going on in a family, but there will be pieces that you miss unless you have something a little bit more formal, some questions that you're specifically going to ask. Also, like I said, self-report. I give my clients a self-report assessment at the beginning of every session. It's the OQ 45, which is outcome questionnaire 45, meaning there's 45 questions. And that kind of gives me both the opportunity to see what's going on safety-wise, because it has some questions that are specifically about client safety. And then it also gives me a sense of kind of a broad range of outcomes, or of like symptoms of what the person is experiencing, that I can kind of hone in on, look at what they're scoring high on, like that's it's hard, it's going pretty poorly, and then I can bring that up. But I might not have known to bring that up if I didn't have that assessment given at the beginning. So I definitely do combine all these different kinds of assessments, and that is what works best for me. So of course we assess, I mentioned earlier, for a number of different reasons, case conceptualization. So this can be, again, observational or self-report or interview, but we need to know what's going on, what it is that is happening in the lives and the systems of the people that we are trying to help. And so a case conceptualization is going to kind of be envisioning all of that. And so if we don't have a way to assess, pull more information, observe, ask questions, then it's really hard to get any true idea of what's going on in the case. As you guys can imagine, having done the case conceptualizations with the Lee family for all of these weeks, if you could have asked them some questions, asked what was going on for them, that could have been really helpful in formulating your case conceptualizations. Another reason is for treatment planning. That's kind of part of, like, as we start with the case conceptualization, and then we think, okay, in order to get where they want to go, whatever their goals are, and usually that's a collaborative process to establish what their goals are. Sometimes it might be as simple as, I don't want to feel depressed anymore, or maybe it's something like we've got a kid who is acting out in school, maybe using drugs, and we want that to stop, or we want to know how to handle it better. So treatment planning is, how do we get from where we are now to where we're going? And as I do assessments with people, especially the first few sessions, I will usually do a mental status exam. I'll do that OQ45. I'll ask questions about depression and anxiety, ask them just kind of give me a history of what's going on. And so I talk about, if we have a map, we need to know both where we are and where we're going in order to make a plan for how to get there. And so that assessment piece really helps know where we are so that we can know how to get to where we're going. And then, like I said, the diagnosis piece, if we want insurance to be able to pay for it, because most people cannot afford the cost of therapy independently. And so they need to be able to use their insurance. And so there needs to be some sort of diagnosis. Now, we've talked in the past a little bit about how diagnoses can be both helpful and problematic, and about, kind of having an identified patient if you're trying to conceptualize things systemically. That can feel kind of unhelpful, both for you as a therapist. It can be unhelpful to have an identified patient who has the problem, but also it can be unhelpful for the entire family if they're trying to conceptualize one person as being the problematic person, instead of recognizing how the whole system is contributing to that, and also internal systems. So being able to do all of those purposes of case conceptualization, treatment planning, and diagnosing is important. And then, of course, like I said, also safety, just helping people be safe. That might be suicidality. It might be, maybe there's some abuse going on, either between a couple, or to a child, or to a vulnerable adult. And so we need to be assessing, be thoughtful, be aware of things that help us keep people safe. Okay, pros and cons. A lot of these you will have gone over when you watched the other lecture. And I have actually included all of the lecture slides for the time periods that I had you watch in that lecture later on. And so when I post this video, I will also post the PowerPoint, and you'll have access to all of those slides for testing purposes later. So you will have those to remember. But generally, pros and cons of formal assessment. We want clients to be safe. We need to have a way to be checking in. And of course, that assessment can happen interview style. How are you feeling? Have you had thoughts of suicide? Do you have a plan? There's a really good suicide questionnaire called the Columbia Suicide Rating Scale. Pretty sure that's what it's called. That just walks the clinician through specific questions to ask, kind of in an interview style. It can be done as self-report, but it's better in an interview style. And if somebody is not safe, self-harm or suicide, then you can create a safety plan with them. And that's a really important piece to have. So assessments also help expand the conceptualization. Maybe you can think of certain questions to ask and you can know what to observe, but when you pull in an assessment, maybe you see pieces that you wouldn't have seen otherwise. Maybe there are things that you wouldn't have thought to ask. Maybe there's ways you can get information pretty quickly that expands that conceptualization beyond what you would have had otherwise. Like I said, it saves time. It's quicker to have my clients fill out that OQ45 at the beginning than to go through and ask them kind of interview style all 45 questions. We could easily take an entire session asking and talking about each question if I was doing it that way. Treatment tracking. So another thing that is important as you're doing treatment planning and creating a treatment kind of a treatment plan, but like how you're going to go from here to there. Being able to say kind of it's never going to be exactly objective, but more or less objectively, how are they doing? Are they getting better? So if you administer a Beck depression inventory, for example, at the beginning, and a lot of times, just because life is how it is, marriage and family therapists are going to be seeing individuals. So this might be with an individual that you're tracking their depression. It might be with somebody in a couple. Maybe one person is presenting with depression, one person is presenting with anxiety, or maybe neither of them particularly look like that, but there are some relational things going on that you want to track. But being able to give an assessment periodically allows you to track how they're doing. So for example, if you give a Beck depression inventory and they are really high for depression at the beginning, and then 4 weeks in, you give them another and they're a little bit lower, and then maybe they go a little bit higher and then they go lower, you can kind of track what's going on and get a sense of, do I need to change something? Are we reaching our goals? Are we on target? So it's not uncommon for people to go up and down because life goes up and down. But you want to be able to have some kind of objective-ish assessment that says, we're done now. You know, your Beck depression inventory assessment shows that depression is minimal to mild, and that looks like you're doing okay. And that can be helpful for people. Maybe they feel like, yeah, I am doing okay. And then when they see that change, look, I've made this much progress, that can be beneficial. And then also, like I said, the assessments can simplify that diagnostic process. So you could have a sense easily of what's going on. Often when you give a diagnosis, it's important to say why you're giving that diagnosis. So for example, if I'm giving the diagnosis of depression, I'm going to want to say what symptoms and for what duration people are presenting with that justifies the diagnosis of depression. So maybe there is anhedonia, that they're not enjoying anything, and insomnia, and so they're not sleeping well, their energy is really low, they have a low sex drive, they feel blue a lot of the time, they think perpetually about self-harm or about death, and that kind of sounds like a good thing to them. Some of these things, and that's been going on now for, say, 2 months. And maybe this has happened before, maybe this is a chronic, maybe it's a recurring. There's also specifiers in the DSM. So you give not just a major depression disorder, major depressive disorder diagnosis, but you would also give, is this recurrent or one time? Is this mild, moderate, or severe? Are there psychotic symptoms? So there's a lot of different kind of modifiers of that. But when you do an assessment, that helps to get a sense of, okay, what is the actual diagnosis? Cons, as it talked about in the other lecture also, if you're using formal assessments and you're only doing an assessment on one person, or if you're using a formal assessment and it's asking questions kind of with some cultural assumptions that don't really fit the cultural assumptions of the person that you are assessing, that can perpetuate biases. It can perpetuate biases about this being one individual's problem rather than a systemic issue. It can perpetuate biases about kind of cultural assumptions, cultural beliefs that maybe this person just doesn't share at all. What is right and wrong can be a very cultural, and healthy and unhealthy, pathologizing and non-pathologizing can be a very cultural issue. Then, like I said, it might not fit with systemic or the theoretical thinking that we have. Sometimes diagnostic labels can be limiting to people. I'll ask a reflection question in a minute about how you see this. Maybe you've had experiences with someone that you know receiving a diagnosis, and sometimes it's really helpful and it means that they get the resources that they need and they can conceptualize things in a helpful way so that they can move forward. Now we know what we're dealing with. That gives us options and resources to use in dealing with it. Sometimes diagnostic labels can be debilitating. Like if somebody maybe gets diagnosed with borderline personality disorder, and then they're like, well, I'm just never going to have good relationships then, and I'm kind of screwed. Or maybe somebody is diagnosed with OCD, and then they kind of use that as a crutch, like, oh, I've got a lot, I'm just feeling super overwhelmed with OCD. I can't go to work. I can't do whatever. And so that, of course, would be unhelpful. Another con for formal assessments is that there is not a clear research-based link that having done the formal assessments, and this isn't just like observation and interview, and because we're doing that all the time, we have to do that. But this is the more formalized assessments, that having done those gives information that actually improves outcomes. So pros and cons. Okay, reflection questions. And maybe you draw on specific personal information and experiences that you have had or others that you know have had for this question, but how do you feel about diagnoses? How do you feel in terms of them being helpful, unhelpful? What are the benefits or drawbacks that you see? And then also another reflection question, what are some challenges that you've noticed about giving formal assessments? So you've given a couple now and had to interpret, well, you're probably still interpreting or getting back that second one. So how has it been? What have you noticed that's challenging? Of course, in this case, you have been giving these assessments to people that you know. As a therapist or a clinician, you would not have that relationship with the person, and they would have come to you asking for help. So that might be a little bit of a different scenario, might feel a little different. But I wonder, just use your imagination and get a sense, maybe, right, how you feel like you would think about, feel about assessments as a clinician. What would be helpful, unhelpful? One of the things that I gave you some videos to watch on is that biopsychosocial spiritual assessment. And that can be kind of a combination of observational, self-report, interview. Often, if somebody is having an issue that has some kind of pieces that sound a little like maybe there's something biological, I will ask them to go and get a physical, get some blood work, have their doctor, maybe there's some some cognitive impairment or something like that. Now, it's certainly possible for there to be some kind of cognitive impairment because of trauma, purely because of trauma. Everything is working biologically otherwise. But maybe they report there's a history of concussion, um, or maybe there are some other somatic things like severe headaches, lights ringing in their ears, whatever. And so when they say, I'm really having trouble focusing and I can't think very clearly and I have all these headaches, probably say, you might want to go to your doctor and get an MRI or something like that, just so that we can make sure that I'm not trying to use systemic methods and therapeutic methods and talking and experiencing to clear up a brain tumor, because that's not going to work. So that biopsychosocial spiritual assessment can be really valuable, can help really fill out that case conceptualization. At least for the BYU MFT program, there was not a lot of, and as you saw in the models that we covered, there's not a lot of spiritual conceptualizations. Like we don't talk about, how does your feelings about God impact this? But people's feelings about God and their relationship with God does impact how they feel about themselves and about their families and what their expectations are. So pulling in some of those spiritual components and asking, and maybe somebody isn't practicing any kind of religion or isn't part of an organized religion. Maybe they have more just kind of spiritual experiences, spiritual feelings. So wherever they are in that spiritual can be good to pull in, to recognize. Sometimes that can be a resource. Sometimes it can be a challenge that, somebody can feel like they're worthless because of some of those spiritual or religious teachings and beliefs. Anyway, so that biopsychosocial, that will probably be something you will want to know about and be able to talk about for a final exam, as well as some of these pros and cons and other parts about assessment. This will be on the final. So as I promised you, so this slide and following, and I'll just show you these quickly, will be in the PowerPoint that I post in the content. So you can look these over also. And she does a great job of having gone over a lot of the things I just went over. So here are all of these, and you can have, like I said, you'll have these as a PowerPoint slides too, but you'll want to be familiar with these things so that you can answer questions about them on the final. I hope you're having a great week, and this lecture got posted pretty late, but here's your reflection questions in this. And we will not be having a Friday lab this week. I have some other meetings that I'm going to, and since we won't be doing case conceptualizations, I figure you can probably get the information about assessments that you need. If you have any questions about assessments, as always, feel free to email, and I'd be happy to answer. Okay, see you later.